Hello everyone and welcome back. This is Ahmad Radwan again, and we are starting at page 327 in surgery, preoperative and postoperative care. Let's start with preoperative care here. What is going to happen? We're going to see a lot of questions, and we're going to try to guess the answer first and see what the answer is right after, and try to discuss how the answer is right and why the other answers are wrong. All right, so preoperative assessment here. Well, the most important aspect of a preoperative assessment is being able to identify comorbidities that preclude surgery. Okay? So, other aspects of preoperative assessment include understanding the modifications that may be needed and to prepare patients for surgery. So, two things here: identify the comorbidities that preclude surgeries and prepare patients for surgery if they have a specific condition that needs modification. All right, so let's start with the first question. It says that there is a 42-year-old man with hep C and cirrhosis. He presents with a large umbilical hernia with intermittent pain. On examination, he has a large amount of ascites. Surgical intervention is being considered here. His bilirubin is 3, his prothrombin time is 32 seconds. Now, INR 2.2, and his serum albumin is 1.9. Which of the following is the best next step in management? Well, it says here that there are 5 options. The first is to proceed to emergency surgery, do surgery, but after giving vitamin K, surgery after total parenteral nutrition, surgery after albumin infusion, or do not perform surgery. Well, of course, this patient will not go to perform surgery. There is a score actually for patients who have hepatitis C or cirrhosis in general, and it considers the bilirubin, the prothrombin time, the INR, and so on, and the albumin, and whether there is ascites or not, and so on. And this patient is unfit for surgery. He's category C, I think, and he's not fit for surgery. Um, It says here the answer is E, of course, who do not perform the surgery. Do not do surgery in any patient with multiple derangement in hepatic risk factors. Any one of the hepatic risks alone, like bilirubin above 2, albumin below 3, prothrombin above 16, and encephalopathy, as suggested by alternative status, predicts a mortality of over 40%. If 3 of them are present, the risk is 85%. All 4, that's just 100% risk of mortality. He's going to die on the table. All right, so the second question here, it says that a 59-year-old man is scheduled for prostatectomy. He has a history of hypertension, COPD, and diabetes mellitus. He takes atenolol for blood pressure, tiotropium, and albuterol for the COPD, and glipizide for diabetes. BP is 145 over 89 millimeter mercury. Hemoglobin A1C is 7.1. Recent pulmonary tests document that the FEV1 is 1.3 and blood CO2 is 47. Which of the following is this patient most at risk of developing? The first, it says here, intraoperative myocardial infarction. The second is pneumothorax. C is postoperative pneumonia. And D, it's going to be hypercapnic failure. I'm not really sure. I don't really know. But let's look at the answer. Well, it says here C. So it says here that severe COPD, which is FEV1 less than 1.5 liter. So that's the definition of severe COPD. It increases the surgical risk, mainly because patients have an ineffective cough and cannot clear secretions. They are subsequently at risk for postoperative pneumonia. Okay, so if a patient who has COPD has an FEV1 of less than 1.5 liter, then you should think that he might have postoperative pneumonia right away because he cannot cough and clear secretions. Okay, we have 2 tables here. I would highly suggest that you would look at the table as we are going through it because that's going to be a lot easier. The table here, it summarizes that summarizes the most important principles in postoperative and in preoperative, assessment. And this is the first table. And the second table here, it shows the calculation of cardiac risk index in non-cardiac surgery. So those are two important tables we can take a look at. Okay, so let's take a look first here at the first table. The first table is organized into three columns here. The first one is the organ system, and it's going to talk about the cardiac, pulmonary, hepatic, and nutritional risk. And then the second one is going to be risk factors in each one, and the modification or interventions that we need to do with the risk factor that we see. So, and the rows, we're going to take each organ, and we're going to talk about the risk factor and the modifications that we should do. So the first one is going to be the cardiac risk here, and we have four risk factors to consider. First, the ejection fraction, and if it is less than 35%, if there is a jugular venous distension, which is just a sign of congestive heart failure, so any sign of congestive heart failure here, and there is a recent myocardial infarction and a severe progressive angina. So again, the four risk factors. First, going to be ejection fraction of less than 35%. Okay, very good. And the second one is going to be jugular venous distension or a sign of congestive heart failure. The third is going to be recent myocardial infarction. And fourth, severe progressive angina. What are we going to do as a preoperative here? If the patient has a ejection fraction of less than 35%, we prohibit non-cardiac surgery. By the way, we cannot, he is unfit for surgery in general, and specifically, I mean non-cardiac surgery here. If the patient has a jugular venous distension or a sign of congestive heart failure, what are we going to do, or the modifications here? We are going to optimize medications with ACE inhibitors, beta blockers, digitalis, and diuretics prior to the surgery. So just give him the proper medication for congestive heart failure. That's it. Okay. How about a patient who has recent myocardial infarction? Well, we do not do surgery for 6 months after MI. That's just it. So a patient who has MI, do not do any surgery for 6 months. Okay? If the patient has severe progressive angina, we perform cardiac catheterization to evaluate for possible coronary revascularization. So if the patient is going, if he's been assessed for surgery and we see that there is severe progressive angina, call a cardiologist and tell him that we need to evaluate that patient first, and then see if revascularization is done and so on, and then we can see the patient after 6 months, if he has an MI, for example, to do the surgery. Okay, so the cardiac risk, and that is done. How about the pulmonary risk here? The pulmonary risk is smoking, if the patient is smoking. He has a compromised ventilation, high PCO2, for example, or if you want less than 1.5, we talked about that. And what are we going to do with that patient or the modification? First, we're going to order the pulmonary function test to evaluate the FEV1. If it is abnormal, we obtain blood gases, and we are going to do a cessation of smoking for 8 weeks prior to surgery. So any patient who is a smoker, stop smoking for 8 weeks, 2 months prior to surgery, and then we obtain the blood, and then we can talk about the surgery again. All right? Okay. Now for the hepatic risk, we talked about that in the first question. If the bilirubin is more than 2, if prothrombin time is more than 16, serum albumin is less than 3, and if he has signs of encephalopathy. We said that in a patient who has only one or a single risk factor positive, a 40% mortality with any, and if he has more or if has 3, it's going to be 80 to 85 mortality is predicted, and 3 or more, it's going to be 100%. And we need to stop that patient, and we should not do any surgery on him. The final thing is the nutritional risk factors here, and it says here that there is going to be a loss of 20% of the body weight over several months, serum albumin less than 3, allergy to skin antigens, serum transferrin of less than 200 milligram per deciliter, and finally a diabetic coma. So those are the risk factors that we can see in a patient, or the nutritional risk factors. So again, 20% loss of body weight and serum albumin less than 3, allergy to skin antigen, serum transferrin of less than 200 milligram per deciliter, and diabetic coma. What are we going to do? First, we're going to provide 5 to 10 days of nutritional supplements, preferably via gut before surgery, and finally, and this is in a patient who has lost 20% of body weight and serum albumin is less than 3 and so on. But what if the patient has diabetic coma or something like that? First, it's an absolute contraindication to surgery. Diabetic coma is an absolute contraindication to surgery. You should not do surgery on a patient who has a diabetic coma. We stabilize diabetes, we rehydrate the patient, normalize the acidosis, and then we can do the surgery. All right? Okay. So that has been the table for the principles of preoperative assessment here. Cardiac, pulmonary, hepatic, and then nutritional. How about the second table that we talked about here? The second table is a cardiac risk index in non-cardiac surgery. We talked about the cardiac risks before, but this is more specific, and I think it can be a good way to see the risk factors here. Okay, so it is divided into 4 things. The first is the age, the second is the cardiac status, the third is the general medical condition, and the fourth is the type of surgery needed. So if a patient age is more than 70, he gets 5 points. So there is a specific point for each of the risk factors that we are going to list here, and then there is a final score at the end. Okay, all right. So and the first thing we said is a age over 70, he gets a 5 points. Otherwise, he doesn't get any points if he's less than 70. Then the cardiac status, it has multiple points here. First, if he has an MI within the last 6 months, he gets 10 points. If he has ventricular gallop or regular venous distension, which is a sign of heart failure, he gets 11 points. If he has significant aortic stenosis, he gets 3 points. Arrhythmia other than sinus or premature atrial contractions, that's going to be 7 points. More than 5 premature ventricular contractions per minute, that's going to be 7 points. That's a little hard to memorize, I think, but we can summarize it a little. If the patient, again, so those are 5 points. An MI, we said that before, is going to get the MI 6 months, 10 points. If he has regular venous distension or signs of congestive heart failure, that's going to be 11 points. If he has a significant aortic stenosis, that's 3 points. Arrhythmia other than sinus or premature atrial contraction, that's 7 points. And finally, if he has more than 5 premature ventricular contractions, that's going to be another 7 points. All right. Now, the general medical condition here, we should consider the PO2 and the PCO2, the potassium, the HCO3, the BUN, the serum creatinine, and the AST, and the liver problems in general. So first, let's see the PO2. So if your patient has a PO2 of less than 60, if he has a PCO2 of more than 50, if he has a potassium of less than 3, if he has HCO3 less than 20, BUN more than 50, and serum creatinine more than 3, elevated AST or a chronic liver disorder or bedbound, he gets 3 points. So again, it's really easy. I know that's a lot of numbers and to memorize, but it's easy. If the PeO2 is more than 60, that's abnormal. Less than 60, that's abnormal. If PCO2 of less than 50, again abnormal. More than 50, I'm sorry, that's abnormal. If the potassium is less than 3, abnormal potassium per se, and HCO3 of less than 20, BUN of more than 50. All these are just abnormal values. The serum creatinine, we have to just memorize that it's more than 3, not just abnormal. Elevated AST and chronic liver disorder or bedbound, that's going to be 3 points. All right? Okay. Just review it multiple times. I think you can get it. And then the type of surgery. It's either emergency surgery. That's going to be 4 points. Intraperitoneal, intrathoracic, or aortic surgery. That's going to be another 3 points. So 4 points for emergency and 3 points if it's intraperitoneal, intrathoracic, or aortic surgery. And then we can add up these points and get a total score. If he has a total score of 0 to 5, that's level 1 risk. Level 2 is going to be 6 to 12. Level 3 is going to be 13 to 25, and level 4 is going to be more than 25. All right. Okay. So this is the multifactorial index for cardiac risk in non-cardiac surgical procedures. Okay. Now let's go to the post-operative complications here. So post-operative complications. A question here, it says, in each of the following cases, which diagnostic tests will likely show the cause of the patient's post-operative fever? So a patient has a fever. Which test can show in each patient the cause of fever? So a patient who had major abdominal surgery as afebrile during the first 2 post-operative days, but on day 3 has a fever of 103 Fahrenheit. So that's the first patient. The second one is a patient who had major abdominal surgery and is afebrile during the first 4 post-operative days, but on day 5 has a fever of 103. Third, a patient who had major abdominal surgery is afebrile during the first 6 post-operative days, but on day 7 he has a fever. Okay, so the first patient and the second and third, they are different, I think. And we should consider different tests. But let's say the first patient here, I think we should consider a chest X-ray. He could have a pneumonia, and the second patient, we should do a chest X-ray again, and the third patient we should do a urine analysis because he can have a UTI. So let's see if our answers are right or wrong. Let's hope they are right. Okay, so I got this totally wrong, I think. It says here that the answer is that the first patient, we should do a urine analysis. And this is the patient that had just 2 days. And the second patient, we should do a Doppler of the lower extremities. That's 4 days. And the 7 days, it's going to be a CT scan of the abdomen. Okay, so it's a good thing that I got it wrong, so we can actually take a look at things and at the same time remember it. Because if you get something wrong, you will always remember it. Okay, so every potential source of post-operative fever must be investigated, of course, but the timing of the first febrile episode gives a clue as the most likely source. So, while not a hard and a fast rule, the 4 W's mnemonic gives a clue to the likely cause of fever. Okay, so we have a mnemonic here of 4 W's that we can take a look at. Okay, so if there is the, it's going to be the W, the first one is going to be wind for atelectasis, atelectasis, or something like that. Common post-op day 1. So, day 1 is going to be chest X-ray. Okay, so day 1, chest X-ray for atelectasis. The second one is water. So wind and then water. Water is for urinary tract infections. It's going to be common post-op day 3. So day 3 and 4 is going to be the urine analysis and urine culture. The third is going to be walking. So the third one is going to be common in post-op day 5. And this is going to be the thrombophlebitis, walking. You should order a Doppler of the lower extremities. And finally, it's going to be wound for wound infections. It's common in post-op day 7. We conduct a complete physical examination and consider a CT scan to evaluate the deep infections. All right. So again, wind, water, walking, and wound. Wind, that's the first day. Water, that's the third day. And walking, that's the 5th. And wound, that's the 7th. And so on. All right, perfect. Now let's have a different question here. It says a 47-year-old woman with medical history significant for large fibroids and anemia becomes disoriented 18 hours after an uncomplicated hysterectomy. What is the next step in management? It says here A, obtain an arterial blood gas, obtain a CT scan of the pelvis, give IV fluids, give lorazepam, or give blood transfusions. Well, let's take a look. Where it says here that she has a large fibroid and an anemia. She becomes disoriented 18 hours after an uncomplicated hysterectomy. Well, I would give IV fluids, but let's see how it goes. Well, the answer here is A, to obtain an arterial blood gas. So again, I'm wrong. There is a long list of causes for postoperative disorientation. However, the most lethal one is not recognized and treated early is hypoxia. Okay. Unless the vignette clearly identifies other possible metabolic causes of disorientation like uremia, hypernatremia, pneumonia, and hyperglycemia. Or a iatrogenic medication, for example, the safer thing is to obtain an arterial blood gases. All right, very good. Now, another question. A 52-year-old woman is found to have brown feculent fluid draining from her wound. Her wound drained 9 days after a sigmoid resection for colorectal cancer. The patient is afebrile, has stable vital signs, and without any complaints. What is the next step in management? Okay. So, first, it's administer IV antibiotics. We order a CT scan of the abdomen. We flush the drain with normal saline. We perform an urgent laparotomy or observation. I would say C, flush the drain with normal saline. Okay. It says here the answer is again wrong. It's E, just observation. Here it says that observation is all is needed. A fecal fistula, if draining to the outside is not serious, it will close eventually with little or no therapy. If feces were accumulating on the inside, the patient would be febrile and would have other systemic signs. This would require drainage and probably a diverting colostomy. Okay, so if the patient is febrile, we do observation only. If he or she gets a fever, we do we'll perform an urgent laparotomy to divert for a colostomy. Okay. It says here the leakage of fecal, gastric, or duodenal content to the outside post-operatively is not an indication for emergency surgery. However, observe stable patients. Dehydration and electrolyte derangement must be corrected. Okay? All right. That's good. All right, so here it says that nutritional support should always first be given via the gut. So you should not think of IV fluids, just think of nutritional support first via the gut, whenever possible, of course. Total parenteral nutrition is almost never the right answer on the exam due to the high risk of infection, and it is needed if there is an upper GI fistula. Though that's kind of rare. So you should think right away of GI, and if there is something wrong with the GI, nutritional support should be via the gut first, and then if there is an upper GI fistula, maybe we could consider the total parenteral nutrition. But it's almost never the right answer, so avoid it. We have another table here. This is kind of like to summarize the features and management of the post-operative complications that we mentioned before, and I think it's a really good one. And we can just go through it, and we will be done with the post-operative one. We are almost 23 minutes here, but I think we should go through it. This is gonna end things in a high note, so and I'll try to be as quick as possible here. Okay, so the first one, it's gonna be fever. All right? Okay, fever. So if a patient has a fever, and the first thing we should think is, or we should consider, is the malignant hyperthermia, which is exceeding 104 Fahrenheit. This is going to be shortly after the onset of anesthetic, like halothane or succinylcholine. We treat with IV dantrolene at 100% oxygen, correction of the acidosis, and cooling blankets. We watch for development of, and we should watch of the development of myoglobinuria. So malignant hyperthermia is going to be right after we start the anesthetic, and we should treat it with IV dantrolene, 100% oxygen, correction of acidosis, and cooling blankets. All right. What are we afraid of? Myoglobinuria. We should watch for that. Okay. Fever again, postoperatively, is going to be bacteremia. It's going to be exceeding 104 Fahrenheit. This is within 30 to 45 minutes of invasive procedures. Um, the instrumentation of the urinary tract is a classic example for that. So if there is a procedure and in 45 minutes we have a fever of 105 or exceeding that, that's bacteremia. And what we do is that we start empiric antibiotics and we draw blood cultures 3 times. So just proper treatment of bacteremia, that's it. Postoperative fever, we talked about that. The first one, it's going to be atelectasis or wind. That's going to be day one. What we're going to do is incentive spirometry. That's the management. Day 3, that is pneumonia. We did not say pneumonia before, right? We didn't talk about pneumonia here, but it could be pneumonia. On day 3, and we do a chest X-ray. We're going to see an infiltrate. We can do a sputum culture and so on, and antibiotics. The UTI, that's going to be on day 3 again, urine analysis and urine culture, and then we give antibiotics. DVT on day 5, we do a double ultrasound at the veins of the leg, and we give anticoagulants, heparin, and then heparin and warfarin or Coumadin. And the wound infection is going to be in day 7. We give antibiotics if only cellulitis, and we do incision and drainage if the abscess is present. And finally, deep abscesses like subphrenic abscess or pelvic or subhepatic, that's going to manifest in day 10 to day 15. We should do a CT scan of the appropriate body cavity if diagnosed, and we do a percutaneous radiologically guided drainage of the abscess. Okay, so that's the postoperative fever. Well, let's now we should consider the perioperative myocardial infarction here. A perioperative myocardial infarction, that's going to be precipitated by hypotension when he is intraoperative, and post-op MI seldom presents with chest pain. So we should consider that when we might not see chest pain. Okay. So if the patient has an episode of hypotension during the operation, we should consider the perioperative myocardial infarction. Of course, in a patient like that, thrombolytics are going to be contraindicated even after the surgery. The mortality rate is going to be higher than for non-surgical related MI. I think in that case, we should consider prevention and the preoperative preparations. Okay. Now, what if in a day 7, a patient presented with tachycardia, shortness of breath, hypoxia, and an increase in the AA gradient? What should we consider here? Well, what we should consider is pulmonary embolus, and of course, if it is in acute form. What we're going to do is a CT angiogram. And if diagnosed, we should anticoagulate the patient with heparin and give an IV C filter or the internal inferior vena cava filter if there is a recurrent pulmonary embolus. Aspiration, it's going to be shortness of breath, hypoxia, and infiltrated X-ray. We do a lavage and remove the gastric contents. We do give bronchodilators and respiratory support. And the steroids do not help. I wouldn't really consider steroids in aspiration in general, so we shouldn't really do it. So what we do in aspiration is that we remove the content by a lavage and do give bronchodilators and respiratory support. Okay. So what happens if we get intraoperative tension pneumothorax here? Attention pneumothorax, postoperative, intraoperative, we're going to see a positive pressure breathing because, of course, there is air that is compressing on the chest, and the patient becomes progressively more difficult to bag, and a blood pressure steadily declines, and the CVP steadily rises. So, easy to diagnose here. What we're going to do is insert a needle to decompress and place a chest tube later on, just like a tension pneumothorax in general. If the patient has a postoperative confusion, what we talked about before is that we said we should consider hypoxia first, and then we can consider other causes, and we should check the blood gases right away, arterial blood gases. And okay, how about if we have ARDS, acute respiratory distress syndrome? What we're going to see is bilateral pulmonary infiltrates and hypoxia with no evidence of congestive heart failure. We are going to give positive end respiratory pressure. A delirium tremens that could happen day 2 to day 3. We're going to see tachycardia, hyperthermia, hypertension, and altered mental status. We give benzodiazepines, barbiturates, our second line, of course, because of the lower therapeutic range, and we watch for seizures and rhabdomyolysis. So that's kind of new to me, the delirium tremens here. I didn't really know it before. And as a reminder, we look for tachycardia, hyperthermia, hypertension, and altered mental status. We give benzodiazepines or barbiturates as a second line, and we watch for seizures and rhabdomyolysis. All right, so that was a quick read of the post-operative complications that we might see. And as a reminder, this has been malignant hyperthermia and malignant hyperthermia shortly after the onset of anesthesia, bacteremia, 30 to 45 minutes of invasive procedures, and the postoperative fever. We talked about the atelectasis, pneumonia, UTI, DVT, wound infections, deep abscesses. We talked about the perioperative myocardial infarction and how dangerous it is, and we talked about the pulmonary embolus and that it presents with tachycardia, shortness of breath, hypoxia, and increased AA gradient, aspiration, and intraoperative tension pneumo, postoperative confusion, acute respiratory distress syndrome, and finally delirium tremens. All right, so that's been it. We are going to start pediatric surgery soon after that, so stay tuned and see you in a bit. All right, bye.